So let's talk about obesity, which of course I think we all know is extremely common. Over 40% of our country suffers from obesity, all right? But it's not something that I think that everybody really understands so well. So let's bring this back to the clinic. So you start a day in clinic, wherever clinic you're in, and a patient walks in the door. He has a history, or she has a history of diabetes, hypertension, and she comes in for a same-day visit. She complains of chronic hip pain, and you notice that she has a BMI of 37.5. So right away, you're like, okay, well, I noticed that she has obesity. What assumptions do you start making about this patient? Let's check our own biases first. And this, I'm not going to call on people, but when you see your patient come in, how do you think she spends her time? What does she eat? Does she exercise? Do you think she's motivated? Do you think she's lazy? Like honest assumptions in your brain. So when you speak to her about how she goes through her day, she says she exercises every day and she eats healthy vegetables. So this is what she claims she does. Is this possible? Is this surprising to you? And I think I want to kind of go back and take a step back and figure out kind of maybe how she got to suffering from obesity, and maybe how realistic this picture is and isn't. Okay? All right. So, of course, like everything in medicine, most diseases start in utero or with just basic genetics. Okay? And I'm going to give you guys a few statements about genetic or epigenetic causes of obesity. And I want you guys to spot which one is not true. And there's going to be a poll that comes up, okay? And the options are having a parent with obesity, having the parent having an extreme of gestational weight, bottle-fed, baby was bottle-fed, smoking during pregnancy, or the birth weight of the baby. Poll to poll. Let's do the first one, I guess. Is it going to make you do all four?
Can you see the poll?
The poll is going to make you do all four?
Yeah.
Looks like you have to do all.
You know what? I mean, you could definitely answer the second one, guys. The other two just doesn't matter. Do it random, and then we'll re-put up the poll later. Okay?
Okay, guys. Don't be shy. It's anonymous.
And I think I did it anonymous. So
Yeah, it is. Like it's 100% anonymous.
Are they doing it?
Yeah, we have 12 answers for now. Come on, guys. At 40%, some more. I want to get at least 50%. Okay. Okay, we are 51%.
Okay, what is it?
The ended rule?
Can't see.
Okay.
Okay. Yeah, so people really weren't sure. Okay, so the answer, go through it, is extremes of birth weight, okay? How big you are or small you are when you're born does not matter, but parents' obesity, especially if they both are, is significantly correlated with increased risk of obesity. A mother's extreme of gestational weight absolutely does. Being bottle-fed, whether or not it's breastfed or, breast milk or formula milk, also is an independent predictor, and I could talk for a long time about why that is or why people think that is, and smoking, okay? There's also a number of genetic causes, which I'm sure doesn't surprise any of you. Look at all the genetic loci associated with increased BMI. The most common monogenic cause of obesity is something called MCR. I'm not going to go into it, just to know that's actually tested, something that was on MixApp and on NEGM+, so that could come up. But I'm not going to go into all the different genetic causes of obesity. Just know that there are a ton that are independently associated, and this, of course, happens before anybody has their first French fry or doesn't work out or whatever it is, okay? All right, so then, of course, we know it's also about the lovely what people put in their mouth versus what they put out, what is the energy expenditure. We all know for so many reasons that there's decreased physical activity now versus 20 years ago, 30 years ago, 40 years ago. Things like Instacart are just making it worse, even though they're much more convenient. But let's talk about eating and why people eat what they eat. Of course, there's always going to be eating disorders, which I'm not going to get into, but that's a big part of it. Stress is a big part. People's culture and their environment. The way that food is marketed to us is, of course, a big deal. Energy homeostasis disruption, which I'll talk about, and the information gap, what people think and what people don't. I remember when I was a medical student, I volunteered at a obesity clinic, and I remember talking to a parent about giving their kids vegetables, and he was like, I give them French fries every day. That's a potato, that's a vegetable, and he really, really meant it. And there is like a lot of misinformation out there, and people start with different ideas. So that's, of course, part of it. All right, and the other thing is, of course, like we have complex controls from our from a neurobiological standpoint of what we eat. So a lot of it is the reward input. So we get sensory input from all 5 of our senses, right? And because of that, and that's affected by memory, taste, stress, and that's going to affect what we call the hedonic system, which I can talk about in a little bit. And there's a lot of evidence that mental stress, which I spoke about in the other slide, and we know it has an increased ACTH cortisol activation. So what that will do is impair self-regulation and promote choosing unhealthy foods that are very immediately rewarding, which are ultra-processed, over more healthful foods, which are delayed gratification, unprocessed. Anybody that's very hungry, who's been in a place where there's like bread out of the oven or a cake right out of an oven or something that's really delicious, how hard is that to overcome your body's desire to just grab that, right? And that's what a lot of people are working against. Of course, your homeostatic regulation, which has to do with a lot of the signals of leptin, ghrelin, which we'll talk about later, is controlled by your hypothalamus. And of course, if anybody has hypothalamic dysfunction, trauma, inflammation, that's going to make a big deal. There's also very, very interesting information that the overconsumption of really delicious foods will affect the brain's reward system. So it stimulates opioid release, decreases your biological stress response, and it can ultimately stimulate like an addiction-like reward versus deficits, which of course promotes compulsive eating. It's very similar to what we think about really illicit drugs. It's the same type of thing. So people have this kind of dopamine activation that you become dependent on, reliant on. And the food that we eat kind of are predisposing us to that kind of addiction. So there's a lot of things that we are working through even before. And I know a lot of you guys are eating, which is good because I just ate one. But it's true. So this, and that's kind of most of the pathways that we're going to talk about. All right. Another thing that somebody might contribute to somebody's obesity is the meds that they're taking. And I'm sure you guys all know this. So this is something that I'm going to hope people volunteer. Otherwise, I'll have the chief call on people. Some of these medicines most of these medicines cause weight gain. There are some that do not. Not the ones that do not cause weight gain. Anybody, it doesn't matter.
Anybody? So they're saying the chat, bupropion and insulin.
Yeah, bupropion. Yeah. Oh, insulin absolutely does cause weight gain. Absolutely.
They're asking if
it causes also water retention and weight gain.
And they're also mentioning Zyrtec, prednisone, olanzapine.
Hold on. They said neurotriptyline?
So Zyrtec, prednisone, olanzapine, and then they're asking, what about gabapentin and methotrexate?
Oh, let's just go through it. You need to show of hands if somebody just guessed something that is weight neutral.
So Bailey is saying olanzapine causes weight gain. And also Antonsen the same. Yeah. Tony saying the same.
Anyone?
Anything neutral for the weight? So Tony saying Abilify is weight neutral.
You are correct. Abilify is weight neutral.
And then Jardians,
Yeah.
Nadine.
Yes, Jardians.
Oh, guys, you're making all the right choices. What more?
Yes. Okay. So Zyrtec, the second generation immunotherapy does not cause weight gain, but first generation does. Okay. A lot of TCAs do. It's the same kind of anticholinergic phenomenon. Nortriptyline does not. Amitriptyline does.
And then Sammy's saying glipizide.
What? Oh, glipizide also significant weight gain. Part of the reason why we don't like it. Gabapentin does, lithium does, Cymbalta does, amitriptyline. Beta blockers can. Some prednisone, of course, and a lot of the SSRIs do. Okay, and methotrexate does as well. So lots of these are on your patient's medication list when they come in, and so this, don't forget to look at their medications because it'll often reveal an etiology, at least for a component of why they're gaining weight or why it's so hard to lose weight. All right, what else? We discussed the environment, culture, stress. I kind of discussed neurobiologically why that is, and I'm sure we've all experienced how stress will change what we eat from one way or the other. And of course, neurological dysfunction, as I was saying, any hypothalamic inflammation, trauma, will cause an imbalance in our body's homeostatic set. Viral infections can cause it. There's a lot of information that your gut microbiome will actually help with neurological signaling and either do a pro-inflammatory and anti-inflammatory state, which will contribute to obesity. I think that's probably out of the scope of what you guys will be tested on, but I'll tell you my obesity board, it was all about microbiome. And then, of course, there's sleep. And sleep is a huge, huge, huge component. All right. Is Dr. Andrelli on? He's not, because I made the cat sleep for him. So I'll just tell him later that he missed it.
Yeah, it's not on right now.
It's okay. I'll give him a hard time later because I made the cat animated for him. Okay, so sleep is not surprisingly an important part of weight regulation. So I don't know if you guys remember what ghrelin and leptin are, and we will talk about that later. But basically, the more you sleep, the less hungry you are. Pathophysiologically, based on how many hormones in your body. And the difference between 8 and 5 hours of sleep is significant. You guys look at this right here. So make sure your patient's sleeping. Ask about it. And this is separate even from an OSA evaluation, which could become part of it. All right. So these are all the reasons, or many of the reasons why somebody can come in being overweight. All right. So let's go back to your patient. So the patient comes in the room. It's a different patient. His BMI is 32. But he doesn't look overweight. Does that mean he has obesity? I hear that a lot, like, oh, I'm telling you he's really muscular. I don't really think he has. I know that it says his BMI is 32, but honestly, you should see him, Dr. Edelman. You should come in and see him. This guy just works out a lot. Okay, so what was the answer to the second question? Do people do that? Remember? We could redo it, but I don't know if that's really necessary. You guys remember, Chief?
One?
It was the second one. It was like, how do you characterize obesity for a BMI of 37?
So I can share the poll again, but I think that they already answered it. So I don't know if.
I think so too. I don't remember what people said though.
But let me
I don't
just
remember.
share it. Do you see it?
Oh, I got it now. Okay, so yeah, so most people said morbid obesity for a BMI of 42, but the truth is it's class 3 obesity. Okay, so I'm going to talk a little bit about BMI right now, and this is testable. This is tested in MixUp. This is tested on your board. All right, we no longer use the term morbid obesity for lots and lots of reasons. We classify based on class. So BMI is great because it's really cheap. It usually correlates with metabolic and fat mass. It's reproducible. It's a really good screening metric. The problem is that even though it correlates with metabolic mass, it doesn't account for individual muscle mass. So when somebody is sarcopenic, it might underestimate their metabolic disease, and if somebody is really like a bodybuilder, it may overestimate how much metabolic disease they are. And if you think about where the metabolic syndrome comes from, it's really in your visceral fat, and I'll go into that a little bit. So the waist circumference is a really good measurement. This is kind of how you do it. When somebody's BMI is between 25 and 35, you can actually get a waist circumference to assess if that person actually has risk factors for metabolic syndrome. So above 35, it doesn't really matter if they're weightlifting, it's still an independent predictor for metabolic syndrome. But if they're the BMI is less than 35 and their waist is really skinny, you can always just ask somebody a pant size. You don't even have to measure it. And they very reasonably might not have obesity as a disease, which we'll talk about. Okay.
Dr. Sorry to interrupt you. We see like your idle timer on your screen, which is kind of blocking.
Oh, no.
Thank you. No, it just popped up. Thank you.
Now you can see everything?
Yeah, now it's perfect. Thanks.
Okay, good. All right. So this is where the visceral fat is. So why do we care about it? All right. So here is over here. I don't know if you guys can see this. This is regular adipocyte, okay? Problem is that at some point, if you have too much adipogenesis, there isn't enough subcutaneous space for your tissue, for your adipose tissues to go. So you end up having an overflow of free fatty acids, and then your adipocytes have hypertrophy, and it causes dysfunction. And basically, it'll, as you see here, it's good because you see that blood supply is not adequate for the adipocyte, so it causes kind of apoptosis, it causes an inflammatory reaction, and it really is a pro-inflammatory molecule that ends up being everywhere in your body, okay? Also, actually, I'm just going to skip this. So I want to talk about adiposity. I can't even say it, even though I was supposed to say it, which is called sick fat disease, and this is why we care. So, of course, we know that obesity is associated with diabetes, hypertension, hyperlipidemia. I'm going to why that is, but there's a lot of reasons for that. But we know that the fat molecule is pro-inflammatory, and now I'm going to ask people, what do you think it happens when you have fat right next to your pericardium, right next to your heart?
Guys, you can unmute yourself or just type in the chat. What do you guys think? So that is saying pushes on the heart, makes you have to pump harder.
So we can talk about that. That is correct, but that's more, we call it a fat mass disease. So that has to do with the actual weight of the fat pushing against them. But it's pro-inflammatory. Anybody going into cards? Yes. Increased atherosclerosis, right? Okay, so we know, especially cardiologists to be, that increased inflammatory markers cause endothelial dysfunction. It causes vasoconstriction. It causes increased calcium. And everything pro-inflammatory makes somebody hypercoagulable, which increases your CVA risk and increases your CAD risk. So really, almost every cardiovascular risk on the planet results from direct inflammation next to your heart or next to your blood vessels. And that's kind of part of what's so dangerous about it, why visceral fat is such a big deal. Okay, and then what about just, it gets all over your other organs, and I'm going to let Julia answer this because of what she's going into. What do you think it causes? There's inflammation everywhere. Or somebody else can, I'm just giving you guys a hint.
Well, because it was the hypercoagulable state?
I'm saying if you have inflammation near lots of your organs, especially things that promote endocrine dysfunction and inflammation, what's it going to cause? What's like a...
Oh, yeah,
Very
cancer.
hard. Cancer. That's why I said it to you, because I was like, there's no way anybody else is going to guess it. Yeah, cancer. Obesity is a huge risk for cancer, especially breast, cervical, colon. These are huge independent risk factors for getting cancer later on. And I think it's an under-recognized risk of obesity, but it's there and it's real. You know, and I can go into each and every one and how much of a risk, basically, except for the liquid cancers. Mostly being obese is an independent predictor, which makes sense if you think about this as a sick fat disease and like a direct pro-inflammatory state right next to organs, which the bone marrow is different, okay? So I think I have so now I have the third poll question, okay? Let's see how well you guys understand a sick fat disease. Look at people, yeah. Yes, peripheral fat also associated with higher estrogen content. Yes, exactly. I didn't go into all of that, but it's true. So the aromatase conversion.
And I also shared the results of the poll.
Can we redo the poll, or this is it?
So these are the results. Like I cannot do it again because they already
You can't redo it?
Yeah, unfortunately.
Okay. So then I'm gonna just read you guys and then can you do a show of hands? Should we do that way, or should I go to people to say what they think?
I guess if people, like, we can, NAFLD might be A, OSA B, osteoarthritis C, and GERD D. I'll leave it here. Can you guys just comment in the chat?
Okay, that works. Okay, so what is another example of sick fat disease, okay? The options are NAFLD, OSA, osteoarthritis, or GERD.
You can either shout it out or just text it in the chat what you guys think. Okay, so they're all saying NAFLD.
Everybody's getting it right. I'm so impressed. I'm so impressed. Everybody's getting it right. Okay, yeah. NAFLD, right? Direct inflammatory effect. And then there's the other one, the fat mass disease, okay? And it's really exactly what we think of. It's the fact that there's additional mass pushing on certain organs in your body. So what does it do to your joints? Okay, thank you. Thanks, guys. Yeah, we have stress. Okay, what about up here? What happens up here? Around your neck. Yes, thank you, guys. Okay, OSA. So, of course, you have tissue compression. And by the way, this has an effect on hypertension, as you guys know, right? So, first of all, because of hypoxia, you're going to have increased cardiac output. There's going to be cardiac pressure overload also due to frequent changes in thoracic pressure. Lots of things, okay. What about around your heart? I might have mentioned before, I don't remember who. Yeah, so atherosclerosis is more of a sick fat because it's from the pro-inflammatory state. Yeah, so LDH maybe indirectly so let me tell you, so if it's restricted, can the heart expand easily? Can it relax? No, right? So, sorry. So it's a cause of, because of pericardial restraint, you have decreased LV expansion and you get diastolic heart failure. So that's a big part. Okay, and then what happens? No. Okay, here's GERD. Sorry, this is meant to be stomach, but it's really over the liver, so it's tough. GERD, of course, will cause compression. It's just compression. And then there's also a theory that because of a mass effect around your kidneys and renal vessel compression, that will cause potential renal vessel constriction, which is, leads to impaired natriuresis and worsening hypertension. That is a theory, but that is one of the theories of one of many reasons why obesity causes hypertension. Okay. So none of these should surprise you that a BMI, as you get greater and greater, is associated with a reduced survival for all the reasons that we were just talking about. And I hope none of this is surprising because of everything that I just mentioned, okay? I'm just flashing this on screen, but we're not going to go through it. Okay, so how do we define obesity? Of course, I gave you the measure, but the Obesity Medicine Association really, really wants us to start thinking of it more like other diseases. And so they have this fancy definition. I'll read it to you, but it's, you know, a lot. Chronic relapsing multifactorial neurobehavioral disease wherein an increase in body fat promotes adipose tissue dysfunction and abnormal fat mass physical forces, resulting in adverse metabolic, biomechanical, and psychosocial health consequences. There's a lot, but I hope that I proved at least that part to you. But I would say that ACE, the American Academy of Clinical Endocrinologists in 2017, wanted to change the entire name of it to adiposity-based chronic diseases, ABCD, instead of obesity, to more focus on the characteristics of physiological effects rather than the weight itself. It hasn't taken on, but, you know, just let you know what's kind of happening in the background, and we'll see how it plays out. All right, this is a mix-up question. You guys are first years. I don't know if you have mix-up, but I really recommend you guys all getting it because, right, Chiefs, we're in the 3-year cycle now where their mix-up will be the ones they study from. 3 years, right? So it'll be the same one for all 3 years?
Yeah, it's a good tool to study and like do some questions. Because in the new world, you will buy at the end, like in your 3rd year, but mix-up, you can kind of use it throughout. So right. If you wanna,
and I think it's the same. I don't think a new one is going to come out till they're done. So
no, I don't think so. Yeah, I think the new one already came, so you can just buy it. It should be the same.
Okay, so we can't do the poll again. If people are willing, you know what? I'm gonna call on Tyler to read it just because Tyler's the one that's in my view.
And I can
okay,
also share the results.
not to answer it. Okay, we'll have everybody answer it. Is that okay with you, Tyler?
Yep, that's okay with me.
Okay, thank you.
Yeah, no worries. I would think the serum lipid panel, just because.
Oh, yes, but I mean just read the question. I don't want to put you on the spot for the answer.
Yeah.
Yeah, I don't want to put you on the spot for the answer. I'm trying not to be mean about this. I just can't hear my voice the whole time.
Yep. So a 29-year-old man is evaluated during a new patient visit. He is concerned about gradual weight gain over the last several years. He does not pay much attention to his diet and describes his lifestyle as generally sedentary. He does not use tobacco products and does not drink more than 1 to 2 alcoholic drinks per week. He reports no problems with non-restorative sleep or daytime hypersomnolence. He takes no medications. On physical exam, his blood pressure is 149/90 and a pulse rate of 87. BMI is 35. His waist circumference is 107 centimeters. The remainder of the physical exam is normal. Which of the following is the most appropriate test?
Yeah, so what do you guys want to get next? What's your answer? Please, A, B, C, D, E. People are brave. Put it in the chat.
These are like the results from the poll, and people are all saying D, which is the serum lipid panel.
Yeah, it does seem that. Okay. You would all be correct. Okay. I just want to point out a couple of the things, and actually a lot of people got this wrong, right? If you look at how many people said TFTs, it's a lot. And of course, when somebody comes in obesity and our patient comes in, you want to characterize their ACD risk, look for diabetes, which for lots and lots of reasons is correlated with obesity. And it's important to think about TFTs and think about CPAP-TN, everybody, but it doesn't mean that you need to check it. It's only if you have clinical concern. So everybody, you should screen for OSA by asking them the STOP-Bang questionnaire, but it doesn't mean you need to get a sleep study on everybody, okay? And in general, for boards, they're going to want you to do cheaper things like history and physical first. So they're almost never going to want you to go straight to a sleep study, even if it's going to be something that eventually you do, okay? And this is just to quickly say, if they have any features of hypothyroidism, check. If they have Cushing's syndrome, disease of Cushing's, which is extremely unlikely, but it's sudden increase in their weight, sudden diagnosis of hypertension, diabetes, abdominal striae, you can think about it, but it's very uncommon relative to obesity. okay? So then what's the goal? The goal is really 5 to 10% of weight loss in order to make significant changes in their ASCVD risk, their diabetic risk, their risk of progression of NAFLD, sleep apnea, everything, all right? So how do we get that done? So let's go back to our patient. How do we help her, you know? So, of course, we want to help her, encourage her to do lifestyle interventions, but as we discussed, she spends all of her day, she spends her days working out, she does eat healthy, so how come she's not losing weight? So is willpower really the treatment for obesity? You know, and it's just about checking our assumptions. Why do we assume that they can't be working out? Why do we assume that they haven't tried? Because a lot of times that's our assumption. And the truth is it's extremely hard to lose weight. And if you look at this graph, and granted it's from 93, but still, it's still relevant. If you look at the weight change with people with low-calorie diet, behavioral modification, or combined, they're all effective at the beginning, albeit combined, of course, much more effective. Once you get 5 years out of treatment, very hard to maintain, all right? And these are people that tried really hard for years. And it's not to say there's nothing we can do about it, but just to make a point that it's very hard. So why is that? The answer is, first of all, it is not a simple definition of the energy you put in has to be less than the energy you put out. It's just too simplistic, and it's not true, and weight regulation is extremely complex. And eating behavior is often the result of like an imbalance of physiological factors that strongly resist weight gain, weight loss, and weakly resist weight gain, okay? So there's a lot to focus on, but really all I'm gonna do for today's lecture is focus on 2 hormones that I mentioned before, because it's also very testable and just something that you guys should know. You guys remember leptin and ghrelin from your step 2s and 3s? Yeah. Oh, okay. Does anybody remember what leptin does? In the chat.
It suppresses hunger, doesn't it?
Yeah, absolutely. Yeah, it's a satiety hormone. Thank you guys. It's a satiety hormone. All right, and it's made in adipose tissues. And ghrelin is the opposite. It promotes hunger. So we see right here that it's in adipose tissue. So what happens when somebody's obese? Do they have a lot of leptin or do they have a little bit of leptin? They have a lot. So when somebody who is obese or who has obesity comes in and says to you, I'm not that hungry, believe them, okay? The other thing is that it's a little bit complex, but a lot of people believe that there's leptin resistance that's similar to insulin resistance. So even if they have a high amount of leptin, their receptors are kind of overwhelmed and they don't really experience the appetite suppression that all that leptin around should give them. But then let's say this person, sorry, I should have put those there. Let's say this person loses weight. What happens to their adipose tissue? Decreases. So what happens to their leptin? That or
Decreases.
Thank you, baby. Yes, it decreases, right? So, and their ghrelin will increase in terms of on a relative basis. So what's going to happen is people are going to be hungrier. And as I said before, anybody who's been really hungry and then there's food put in front of them when they're really hungry, it's really hard to resist. And it gets just harder and harder the more weight people lose. And it's because of strong biological forces, evolutionary forces, that, you know, your body doesn't want to lose the fat that it has gained. And it's hard. It's not impossible, but it's very, very hard. There's some other parts, but I'm not going to go into it. So why does it matter if we assume that somebody is just not working out or not trying, okay? And this is a Twitter from a dissertation professor who wrote this kind of inflammatory tweet a few years ago. That, of course, this guy got a lot of pushback. I actually think he might have been fired, but it did create a whole firestorm of commenting and debate, okay? And so I guess this is helpful, right? And so one study of 2,500 women from a weight loss support group said that 70% of them had experienced direct stigmatization from their doctor. Half of them said it happened more than once, and the doctors were the leading second source of stigmatization. Now, and studies suggest, and I'm sure this is not surprising, that when patients feel judged about their weight, they have less trust and lose less weight. And I would imagine this isn't surprising. It's pretty intuitive, okay? And people don't want to feel judged. People don't want to feel like, you know, they are looked down upon. So what do patients do? Often they'll just avoid seeing us. And often, most likely, somebody with obesity already has thought about it and already has complex feelings about it. I'll read one of these. That a woman said, no matter how many friends I had or how good I was at what I was doing or how successful I was, I always felt like I wasn't successful enough or had enough friends or people really liked me because I was overweight. I hated myself more than other people hated me and were made to feel like we're worthless. And so I'm sure this doesn't surprise people, but how helpful is it if somebody comes in and then a doctor reinforces those stereotypes and makes them feel less than? So because of that, I think what's very important is that we think about the language that we use when we speak to people who are suffering from obesity, all right? And here's some just general terms that we can think about, and there's a lot to do, but in general, we don't use morbidly obese anymore. Things like fat, heavy, weight problems, diets are not encouraged. Instead, we focus on the weight, on eating habits, on physical activity. And you can just say to your patient when they come in, like, is it okay if I talk to you about your weight? Chances are they've thought about it. They have things that have worked for them in the past, have not worked for them in the past. What they think is the cause of their obesity, and it will help even start the conversation and engender trust. So I would just think about these things when you next speak to patients who suffer from obesity, okay? Good, and I didn't want to do too much. So this is just a summary slide. We'll come to the end. You know, obesity is a complicated disease, very hard to lose weight, but it's chronic, it's a real disease. It should be thought of like any other chronic condition. It's the most common disease in our country, with over 40% now, almost 50% of people suffering from it. And there's significant morbidity and mortality. And just like other diseases, be it, of course, HIV, diabetes, cancer, we don't really focus on shaming people for how they got there, but we work on, okay, how do we deal with it now? How do we get them to the next place? That is really, I think, how we should focus on helping our patients that suffer from this very significant disease. All right? And I know we all have Zoom fatigue, which is why I tried to make this a little bit faster, and maybe next time we'll all be in person.